Hey everybody, it's Dr. Schiller. Welcome. I hope you're feeling as well as possible today. Today we're going to talk about how to think critically about medical headlines and medical stories and even medical research. If you have a chronic illness or chronic pain, you may have figured out by now that part of what's going to help you feel better and heal is figuring out what you can do for yourself and figuring out what you can do in the realm of nutrition and diet and lifestyle and mind body and even possibly knowing how to help your doctor make good choices, because not all docs are so great at managing chronic illness and chronic pain. And the better armed you are, not only with the facts, but how to interpret those facts, how to understand and think critically about whether they're relevant to you, that's going to help you. So we can't obviously do medical school on YouTube or my blog, but I can give you some basic ideas. And the problem as I see it is like this. There's a ton of medical information out there, and there's a lot of really bad headlines. There's bad headlines that take a kernel of truth and blow it out of proportion and distort it to make it a really compelling headline. And then there's a lot of docs who might be well-intentioned people and might be really good at doing their kind of like the way they do medicine, but they might not be so good about chronic pain or chronic illness. And they might also not have the greatest training in how to think about research in challenging situations that aren't so straightforward. And so a lot of confusion can come out of that. And there's two main kinds. One kind is oh yeah, I heard about this really great thing and I'm sure it's going to help me. Maybe you've said that to yourself at some point and then you find out that it doesn't and it becomes disappointing. And I've seen a lot of folks who kind of like go on this roller coaster of like, oh yeah, I hear it, oh no, I found the and then it just gets to be a bummer. It creates despair over time. And the second thing is that there are things that could actually be potentially helpful for people, but because of the way because of the way medical research is done and the limitations of research or the way it's presented, and a lot of docs think about it, they're not willing to try things that make sense. So let's try to understand a little bit about that, and I hope it's going to be helpful. So here we go. Just first of all, I want to acknowledge for starters that I'm going to say a lot of hard things about research and its limitations. But the fact is we do need good research. Good research is what lets us do a lot of good stuff, Good research is why people who used to die from infectious diseases and heart attacks don't die anymore. Good research is starting to understand chronic illnesses and autoimmune diseases and inflammatory illnesses, and people who used to have horrible, disabling, disfiguring, painful conditions frequently can live a much better quality of life because of good research. And we haven't figured everything out. And the key thing is knowing what to do on the edges where research doesn't have the best clear answer. Because you need good research, good studies that are relevant, well-designed studies about relevant clinical questions, but then you need to be able to take that data and interpret it. And so the first interpretation is the person who did the research, who writes it up and writes an article about it. And then the next thing is the people who read that research, the doctors, the experts, the various kinds of people, and more, unfortunately, bureaucrats in insurance companies who are trying to take research and limit care, or how can we save money by saying no to that and yes to that, and all sorts of crazy distorting forces. And as a lot of what's online, it's not really about helping you. It's not about truth. It's about getting clicks. And the headlines that get clicks and the articles that clicks are eating things that are easy to read and things that give you that buzz of dopamine and think, oh yeah, I've got an answer here for you. And they touch your heart and they learn to think about what hurts you and they nail you and they get you sucked into it. But they're not necessarily there to give you the truth. And so you got to learn to think critically to a certain extent so that when you're reading stuff online, you can ask some of the right questions. So, the real question is, what does it mean to you? And is it useful to you? And who are you and what's your condition and what's going on? There is a movement in medicine that started back before I was training. Maybe it's 40 or 60 years old, I'm not sure, but it's evidence-based medicine. And the way it was started, the authors who originally wrote about it, Dr. Sackett and his colleagues in Canada, maybe they were in England, I'm not sure. The whole bottom line though was like this. They looked at it as two parts. One part is let's look at levels of evidence and realize that we have to stratify what's good evidence and what's bad evidence, or what's better evidence, what's more compelling evidence, more likely to be accurate and not have errors. And then let's bring that together with like clinical experience and compassion and understanding of our patients and what they really need and what their values are. So it's kind of a bringing together of the science and the mathematics of all of it, plus clinical stuff. And, I'll talk more about this in a bit, I think, but there's a lot of kind of fanatics about evidence-based medicine out there who are kind of like religious extremists. They're not even really scientific about the way they talk about it. They're like, oh, well, if there's no randomized controlled trials to prove that this is true, it must be false. We'll unpack that in a bit. It's just a complete distorted thinking. And the outcome of it's the real problem, because they're saying, oh, well, let's talk about it later. We'll get to it. Look, the way I see it is like this. There's like 6 assumptions. 6, or sort of miscorrect, distorted thinkings that I see a lot in this area, and I just want to bring them up so you can start thinking about it and start thinking about, okay, when I'm reading a medical article online or when you're talking to your doctor, how to think critically a little bit about it. So the first thing is this assumption that statistics apply to individuals. No! Statistics are about populations. And part of the art of medicine is asking the question, do these statistics apply to this person who's in front of me in my room right now? And, the worst case of the distortion of this is like, you got this one person who had an experience, and maybe they have an illness. I see this all the time. You go on a Facebook group for people with chronic neuropathy or fibromyalgia, and someone asks an innocent question because they just got a diagnosis and they want to know, is this going to get worse? Does it ever get better? And you always get a bunch of people who are like, no, it only gets worse. You're going to get worse. You're going to get disabled. Get ready for it. And like, okay, that was their experience. They did a research study. It was them, N of 1. And they're trying to extrapolate that and say that it's true about everybody. And it's so profoundly destructive. It really bums me out. I might find myself going on those groups and being like, don't listen to those people who tell you that their experience is going to be your experience. Because it doesn't work that way. We are individuals. That is profoundly, hugely true when you hear one person talking about it. And don't believe them. Don't believe almost anybody who says that this was my experience, so it's going to be your experience. Walk away. The reason we developed quantitative medicine and quantitative methods in research is to look at populations and say, well, you know what, that might be true for that one person, but what's going on? What happens most of the time? And so that's what good research does. When it's well designed, you take a group of people and you say, what's happening most of the time, and who does it happen to, and a bunch of other questions that we try to figure out. But there's more refinement to it. Because, and here's part B of the whole, does the research apply thing. Who is the population they studied? Are they like you or not? And so, for instance, there could be a study of people with chronic back pain, but they could be people where the researchers didn't carefully determine, were the people, did they have risk factors that can make back pain worse that they didn't account for? Stuff like smoking, stuff like being sedentary, stuff like anxiety and depression or post-traumatic stress syndrome or obesity or diabetes or various other conditions where if you don't control for it in the study results become less meaningful. If you do control for it in the study, then you have to, when you read the study, you have to ask yourself, am I like the people in that study? And if I'm not, then it probably doesn't apply to me so much, or it might not. Okay? Part C is like this. You can have great research, and it could come with some statistic that really creates a bummer in the wrong way for people. And you see it a lot with death rates. People have certain illnesses where a lot of people die. And so, not upon us. It shouldn't be. Forget it. It shouldn't be about you. But just as an example, a certain kind of cancer where they found that the 5-year survival rate is only 30%, which means 70% of the people die. And so if somebody comes to you and you have that kind of cancer and you see a doctor or you see somebody else who says, oh yeah, that's a serious thing and you have a 70% chance of death, walk away and don't listen to that person, because you can't say that. Even if it's good research, 30% people lived. 70% of the people died at 5 years. For one individual, your likelihood of death is either 0 or 100%, and you don't know until 5 years, because there are so many variables that could determine whether you're in that 35, did I say 30 or 35? 35% or the 65%. I hope I didn't mix up the numbers. But the point is, I hope you get what I'm trying to say, is that there's so many variables that determine, like, okay, a high percentage of people did die. But, like, what were they like? What were they doing? What was their mindset? What was their level of happiness? How did they take care of themselves? What kind of treatment did they get that the doctors didn't know about? What other issues did they have that they didn't know about? It's complex, and you're an individual. And individuals are not statistics. And so don't believe it when someone tries to apply statistics to you as an individual. Yeah, I think we kind of covered all of that then. Yeah, let's go on to the next thing. Number 2, what does normal mean, right? And I'm supposed to be normal. And this is really relevant when it comes to diagnostics and testing. And it flips me out a lot, like people will come to me. I see people who have chronic pain, chronic illness, stuff that, they've seen other doctors, they didn't know what to fix. Okay, so we should look at some of your research, or some of your lab data. And the patient says to me, oh, my doctor did all the tests, they said they're all normal. And I'm like, okay, I need to see them. They're like, why? The doctor said they're normal. And, the patient comes to me. I actually had someone like this not so long ago. And the person had chronic pain with depression. And I looked at the tests the doctors did. First of all, they didn't do all the tests. That's one of the other things. So when the doctor does the tests, that's according to what that doctor thinks is relevant given the person's presentation. And if that doc is not really an expert in dealing with that particular condition, they may have not gotten all the right tests. So that's just one thing. The second thing is, in this case, this guy had a normal B12, vitamin B12, really hugely important to neurotransmitter synthesis, to the way the nerves function, to DNA synthesis, cell division, foundational thing. And this guy's B12 is 230. And the normal range of B12 is 200 to around, I think, like 900 or something like that. And so his doctor said, oh, your B12 is okay, it's 230. And the guy's like, great, B12 is okay. And I'm like, no, hang on a second. Your B12 is 230. It's on the low end of normal. And you've got a neurologic psychiatric disease where your brain's got something going on. You need to have a B12 that's not on the low end of normal, because it might not be normal for you. So, like, think about shoe size. I wear size 12, and my wife wears size 7. If I try, those are both normal shoe sizes. If I try to wear her shoes, they're not going to be very comfortable. And if she tries to wear mine, she's going to fall down the stairs. Forget that. I didn't say that. But no, she's not going to fall down the stairs. But the point I'm trying to make is that normal doesn't mean normal for an individual, once again. In this particular case, part of what we did is we checked something called a methylmalonic acid, which is a kind of functional test of how the B12 is functioning in the body. And his MMA was high, and that means he didn't have functional B12 to a high enough degree, and we gave him B12, and that had a big impact on what was going on for him. And so that happens with various other lab tests and other kinds of diagnostic issues where normal range isn't necessarily normal for you. How do we know normal range? What does that mean? They look at a population and they see what's the mean, and they say we assume it's probably in a bell-shaped curve, and we take 2 standard deviations, so 95% of the people fit into this range, and that's normal. Well, again, what if you're not the 95%? What if it's not normal for you? So complex stuff, don't assume normal is normal, especially when you have a particular laboratory parameter that is at the bottom end or the high end of normal, and you've got a condition where that laboratory measure, that thing they're measuring is incredibly important. So you got to think critically about that. All right, it's about individuals, not about populations. Normal values are about populations. Okay, so the take-home message so far is that statistics in general are not really applying to each individual. They're helping us make medical decisions. But a good clinician is going to think about you as an individual and think about your lab tests and think about all the statistics in a way that is about you and your particular individual situation. Okay, number 3. One positive study means it must be true. No, not necessarily true. We see this all the time. And there's reasons why one positive study might not make it true for you. The first of all is that there can be false positive studies. There can be studies where the statistics or the study design wasn't done right or wasn't enough or wasn't precise enough. So basically what they've got is a false positive result, and they didn't catch it in their statistics. And so it's just, they'll retest the study and they find that they can't reproduce it. That happens with medical research. And the reason this is important is because you could hear about a positive study and say, wow, yeah, great, this is relevant to me, but meanwhile, it wasn't a really good study. The second issue is like, what if the study's not generalizable to all kinds of people? It gets back to the issue of populations and the fact that there's more variability among people than we think. Genetic variability, lifestyle variability, all kinds of variables. And so there's individual variability, and even in the same disease name, there can be variability. I see a lot of people with fibromyalgia, so I'll talk about that a lot. You know, some research came out in the past couple of years about alterations in immune function and the presence of certain immune chemicals called cytokines. They're like chemicals that the body uses to communicate among immune cells and balance and, you know, direct the immune system, the communication system. And they found a certain profile of cytokines that seem to distinguish people with fibromyalgia from people with other rheumatic diseases. And I think they did one other study of distinguishing people with fibromyalgia from people without fibromyalgia symptomatically. And to my eyes, there weren't so many studies and there weren't so many patients. And then they started going out and they basically created a test that they got approval to bill for the test. And they're using that test to diagnose people to put them in a trial of a particular, it's actually a vaccine from way back that has promise in shifting those cytokines, those immune chemicals. And, you know, to me, that might be useful for a lot of people, but I heard a lot of people getting really excited. We've got a diagnostic test for fibromyalgia. But the fact is, fibromyalgia is this multiple factorial thing. And we've got a lot, and I'll talk more about this in a minute, but there's a lot of different profiles and a lot of different kinds of people who have fibromyalgia. And to assume that, oh, this is a positive test for fibromyalgia, it's going to help me, that might not be a good assumption. So you really got to take these things with a grain of salt. You got to find someone who can help you understand whether it's relevant to you or not. Okay, next one, number 4, which is basically false negatives, right? False negative result, they call it type 2 error in the statistics. Type 2 error is when, I don't want to get too technical about this. Here's the thing. One of the main things we like to do in medicine and medical research is take a population and 2 different groups, and you give one group the test, the therapy you want to use to see if it works, and the other one you give a placebo, and you compare them. And depending on how the data come out, there's a statistical test that can tell you whether the difference between those groups was actually statistically significant. And if it's not statistically significant, it could have happened by chance. And the whole idea is like, I don't want to get into talking about null hypotheses because that's going to confuse things. But the point is, you could have a study that basically comes out as a negative study because of the statistics. And that result isn't so negative. You know, the whole question is this group different than this group, right? And when the study's negative, it means, no, there's no difference. There's a great epidemiologist and statistician, Andrew Vickers, wrote a great book called What is a P-Value Anyhow? And he talks about this. He's a very humorous guy. He says, Dr. Vickers, I played basketball with Michael Jordan last week, and we did three free throws together, and Michael got 7 in a row, and I hit 4 and missed 3. So I wanted to see if he was a better basketball player than I, and he went out there and he did a statistical test because he's a statistician, and he found the p-value was 0.07. And we all know, if you know medical research, that a p-value of 0.07 means not significant, no different. His conclusion is he's got game on Michael Jordan, right? So I hope you get the idea, right? And what it relates to is a really real clinical situation that I've heard so many times, which is this phrase that is, there is no significant evidence to support the notion of blank. I saw a beautiful article in JAMA not too long ago where someone called it the 6 ugly words of evidence-based medicine. There are no data to support it, or whatever it is. The point is, there are no data doesn't mean it's false. Another way to say this is absence of evidence of an effect is not evidence of absence of the effect. And the way to bring this home to you is like, there are no data to prove that looking both ways before crossing the street reduces death rate for people crossing the street. And there are no data to prove that having a parachute when you jump out of a plane is likely to save your life. And there's no data to prove that a person with a blood pressure of 60/40 with a high fever who looks like they've got a really bad pneumonia is more likely to live if you admit them to the hospital. But we do those things because they're commonsensical. We do those things because there is no data, but when we understand a little bit about what's going on, and we've seen God forbid, an animal get hit by a car, or our parents taught us look both ways, we believe it and we do it. And it doesn't mean we should make decisions based on faith because someone said it, but it does mean that we need to be critical about when there is a research study that says that we did not find evidence. And we need to be critical about when an expert says there's no evidence to show that this treatment helps this condition. We have to ask, well, what do we know about that condition? Are there any treatments that can help that condition? If not, we have to look at other kinds of evidence. Hope that makes sense to you. This is probably a good place to talk a little bit more about the evidence-based medicine fanatics, because those are the people who will say, well, there is no evidence to support using this treatment to treat that person, so I'm sorry, I can't prescribe that for you. Or that doctor prescribed it for you, and they go on a witch hunt and they want to shoot down the people who do things where there is no randomized controlled trial evidence. But if you step back and you critically ask, well, what can you do for that patient? They're suffering. That person really doesn't have an answer. From what I've seen, I mean, I'm not an expert in this particular issue of who are the people online who are kind of the evidence-based medicine extremist fanatics, but the ones I've seen are surgeons and ER doctors and people who aren't so much dealing with people who have chronic problems for which conventional medicine doesn't have good answers. A surgeon often has a good answer. Surgical thinking processes tend to be more cut and dried, like, okay, this guy is bleeding in front of me, and we've done studies showing that this procedure is better than this procedure for fixing a lacerated spleen, so do this procedure. And it's good. I'm glad they're thinking about evidence in that case. But when you're looking at a situation of a chronic illness that's causing a lot of suffering and disability and misery for people, and you're saying, no evidence, so we're not doing anything, that's just cruel. And that's not bringing in that second aspect of evidence-based medicine, which is clinical experience and compassion and taking into account the patient's situation and their values and what's going on in particular for them. All right, we're getting to number 5 of 6, okay? These are the 5 assumptions, just to review if you're coming in late, why you want to think critically about medical research and why you want to think critically about headlines you might see and articles you might read on blogs or even the New York Times or whatever supposedly reputable news source, okay? So this, number 5, I'm going to call this the 4 blind man and the elephant issue, right? And it's very related to this pervasive issue in modern medicine, which I like to call the one disease, the one diagnostic problem. The one disease, one cause, and one solution problem. And that was part of what changed medicine when we developed antibiotics, because suddenly people with one disease like pneumonia, who would normally have died, got diagnosed as having the one problem, which is pneumococcal pneumonia, and they got one treatment, which is penicillin, and instead of most of them dying, most of them were living. And so a lot of medicine shaped by that, we're looking for one cause principle. And what it does is causes us to do the four blind men and the elephant issue. If you haven't heard the story, four blind men are walking through the forest, and they've come up to an elephant who's just sort of tied there and sitting there. And they go up and they want to know what the elephant is, so they touch it. And one guy touches the side of the elephant, and he says, "Oh, it feels like a wall." Another guy touches the trunk, and he says, "I think it's a tree." Another guy touches not the trunk, he touches the legs. He says, "I think it's a tree." Another guy touches the trunk, and he says, "It's a big hose." And another guy touches the tail. He says, "I think it's some kind of vine." So look, it was an elephant, and it's got different parts to it. And these guys were blind, and they had their one channel of understanding, which was their hands, applied in different places, and they each one came up with their view of what it is. And those four guys started fighting with each other, and they couldn't get along. And that was the end of their friendship. Isn't that unfortunate? Happens all the time in medicine. Let's go back to fibromyalgia as an example, right? If you follow the literature about fibromyalgia, you'll understand that, well, fibromyalgia is caused by brain sensitivity. And fibromyalgia is caused by peripheral neuropathy, small fiber neuropathy, the nerves drop out. No, fibromyalgia is caused by inflammation. No, fibromyalgia is caused by alterations in the stress response. No, fibromyalgia is caused by dysbiosis, changes in the gut bacteria. The list goes on and on of all of discoveries of the things that have been found to be fairly unique and distinguish people with fibromyalgia from people who don't have fibromyalgia. But the big problem is the four blind men and the elephant problem. Because you got people thinking that, oh, this is the answer, so let's find a solution based on this answer. And the roller coaster has gone up and down on this one over the years. And if you really look at the basic science underlying all this stuff, you could actually see a reason why all of those things are true. Yeah, there's small fiber neuropathy, and yeah, there's central sensitivity, and there's increased inflammatory markers, and there's brain inflammation, there's hormonal abnormalities, and stress system abnormalities, and mitochondrial dysfunction. And if you look at it from a systems biology point of view that looks at complexity, then what you'll see is how those things are all sort of potentially related to each other. And so hopefully in 10 or 20 or 30 years, when we get the big enough data sets and we get enough sort of research will to start looking at fibromyalgia as a systems problem, we're going to start probably piecing that stuff together. In the meantime, we've got conventional medicine going either, oh, here's the problem, let's give them antivirals. Here's the problem, let's give them this. Here's the problem, give them that. Or standing back and saying, well, central sensitivity, we don't know what causes it. Meanwhile, those of us who are studying systems biology are doing a systems approach and dealing with the multiple factors simultaneously. Anything else to talk about here? I think that's probably enough. One little other point to make, just like there was a recent study, and again, this is the issue of looking at too narrow of a problem. When medical science looks too narrowly at a chronic problem, they frequently miss relationships that are important. For instance, there was a recent study that I saw where they were looking at people with chronic pain, and they wanted to understand the influence of nutrition and inflammation in chronic pain. So they studied a nutritional inflammation, and they studied inflammatory mediators that show inflammation, and they studied pain scores. They didn't study stress levels. They could have measured heart rate variability, which looks for the autonomic nervous system response. We know that people with chronic pain frequently have autonomic disturbance. We know that alterations in the autonomic nervous system can affect inflammation, and they can affect pain perception, but they didn't study that. And so they're looking at a system like one or two blind men looking at an elephant, and it doesn't really get good results. So critically think about that. If people are looking at some kind of clinical problem not broadly enough, you might want to think critically about those results. Next and last thing, and this will be brief, is that we've got a hubris. We've got a problem with kind of scientific arrogance. Scientific arrogance is the thing that says, science has got it all figured out. So let's just get some measurements and do some tests and we'll know what the problem is. And that's often so not the case. And if you study the way medical diagnostics and therapeutics have developed over time, you'll realize that. You'll realize the map is not the territory. And you realize that, unfortunately, the tools that we have at hand are what gives us data that lets us make hypotheses about what the problem might be. So if I'm a medical researcher and I'm trying to understand some kind of problem, I take the data I have and I make a hypothesis, and then I do some measurements of that disease. Well, if all of my data is coming from a narrow perspective, if I'm just the guy who touched the trunk of the elephant, and I'm using that information to make a hypothesis to study the elephant, then I might miss all of the data that would come if I touched the leg or the side of the elephant. And over time, hopefully science develops in that way, but there are a lot of people who are kind of in their silos, and they're not really looking carefully to see that, you know what, my tools are affecting my hypothesis, and so my hypothesis affects the data I get, and my data affects the tools, and it's like, it's like a bit of a vicious cycle that keeps things stuck and small and not seeing the big picture. A related example, for instance, is just the way imaging goes, right? So like decades ago, we had x-rays. So someone would come in for back pain and they get an x-ray. And sorry, you don't have a broken bone. I think you're okay. Go home and deal with it. And that person's still in a lot of pain. And then CAT scans came along, which is like a really sophisticated x-ray. And suddenly they were able to see that, you know what, we can see the discs in the back. We knew we had discs because of autopsies, but now we can see the disc, and oh, you've got a herniated disc. That's the problem. Or you don't have a herniated disc, or you don't have enough of a herniated disc, so you'll get over it, don't worry. And meanwhile, the person's still in pain. And then MRIs came along, and we developed a much more refined look at all the soft tissues in the body. MRIs are much more subtle than CAT scans for looking at soft tissue issues. And we're able to say, you know what, that's a tiny disc herniation, but it's pressing on your L5 nerve. And you've got pain going down on your foot. And so that's probably what's causing your pain. So there we have a diagnosis because our technology has gotten more refined. Same things happen in fibromyalgia. Up until I think it was the 1980s or so, people with fibromyalgia were just hysterical. And whatever, don't get me started going down that road because it's not pretty what happened to a lot of people. Because people with fibromyalgia look normal, but they've got really sensitive pain pathways. And a lot of people just told, get over it, stop being such a whiner, take an antidepressant, blah, blah, blah. Over time, we developed more sensitive tools. We developed functional MRI scans and PET scans that let us look at actual brain areas that light up when a person is experiencing suffering from pain. And we were able to see that people with fibromyalgia actually have a lower threshold for pain. You press with a certain amount of pressure on a person without fibro and one with fibro, and a person with fibro, their brain lights up in that sensitive pain sensitivity area. So the point is that medical technology is evolving. If there's a problem and medical technology doesn't have an answer, it doesn't mean it's not a problem. It means we have to be open to seeing things develop. We need to use other tools. We need to use our common sense. We can't always rely on technology because technology is not perfect. Science isn't perfect. We need science, but we need to know its limitations. So it's a tricky situation because what's the answer? What do you do? If you want to be using the best research available and also using common sense and compassion and clinical expertise, how do you go down that tricky road if you're trying to find your own healing path? My view is that if you've got a chronic illness, if you've got chronic pain, if you've got fibromyalgia, chronic fatigue, you kind of have to be your own guide. You can find people to help you, but ultimately it's your life, it's your journey. And so the first thing is not that you should go doctor shopping to do exactly what you want, but you should find a doc who's got a nuanced approach. And you can learn that when you talk to someone. You can hear whether that doc is able to say, you know what, we don't have any good evidence about this, but I think we need to do something. So let's think about the evidence we do have. Let's think about clinical experience. Let's think about mechanism. Let's try this. Someone who's clearly thinking out of the box in a critical way, it's a good sign that they might be able to help you think more carefully. You want that person, and you want to also, on your own, understand false positives and false negatives, like the things I talked about above or earlier. So finding someone who can do that, who can do critical thinking with you, and learning to think critically on your own. The other thing is, I personally think you should keep a journal. If you have a chronic illness, if you got chronic pain, And one of the things in the journal is writing down everything you've done, all the treatments you've done, and what's been the outcome. And that way, over time, you can start to learn things from your own experience. And you can pull things out, and you might want to share that with your clinician if they're interested in hearing it. And if they're not interested in hearing it, you might want to find another clinician. Journals are helpful for other reasons too, because it can be a great place for kind of emotional healing and clearing and dealing with stress and frustration, and just kind of keeping track of the positive things you're doing for yourself, whether it be diet, mind-body therapies, tracking, am I on a regular basis actually sticking to my regimen of how I want to take care of myself? The exercise, the eating, the avoiding this food or that food. And so you give yourself an objective sense, kind of an N of one research. Hey, I did this and I felt better. Or I did this and I didn't feel better. So anyhow, I hope that's helpful. Bottom line is, what I'm here to support you to do is to learn, to grow, to help you self-manage, to help you deal with the stuff that the best of conventional medicine can't help you deal with. And I wish you well on the journey. Thanks for watching.